to be having a VSIM on a cord prolapse, which is a medical emergency. So hopefully this PowerPoint will add some insight in that. Normally when you deliver a baby, the baby head is well against the cervix, and then the baby's head, once the cervix opens, will descend down the birth canal and be delivered. But in an umbilical cord prolapse, what happens is the water breaks on its own, which is spontaneous rupture of membranes, or SROM, or else the doctor will break the bag of water, which is artificial rupture of membranes. And if the water breaks prior to the head being well engaged against that cervix, sometimes what happens is the cord goes through that cervix into the birth canal prior to the baby's head, and then the head of the baby will drop down onto the cord, causing severe cord compression and lack of oxygen to the baby. It is an obstetrical emergency because the cord is blocking oxygen and blood flow to the baby. In most cases, a C-section is necessary and should occur as soon as possible. So these are one of the cases where it is an emergency cesarean section. There are certain people that are at risk for a cord prolapse. One of them, if the baby is small for gestational age, or the baby hasn't grown properly and is small, which is intrauterine growth resuscitation, which is a small baby due to lack of nutrients and oxygen from the placenta. And versus the small for gestational age would be like a preemie. So another risk would be an unengaged fetal part, as I told you about, where the bag of water breaks, the head's not well applied, and then the baby's head comes right down on that cord. Artificial rupture of membranes is when the doctor ruptures the membranes. I used to see more cord prolapses probably in the 90s, when doctors would break the bag of waters to rush things or hurry things up for the woman, and not always in a bad way, but felt that they were doing the woman assistance by breaking the bag of water. The head would have more compression against the cervix, which would cause the cervix to dilate faster. Although sometimes if they broke that water when the head wasn't well engaged, that's when we would get a cord prolapse. Polyhydramnios is when there's just too much amniotic fluid, and sometimes with that, the cord is more likely to drop when that water breaks. And multiple gestation is another risk factor. Medical management, a lot of times, whenever the bag of water is broken or breaks on its own, your first nursing response would be to check on baby to make sure baby tolerated the procedure well. If you look up for the color and the odor, you look under the gown and you see a cord, of course, you would immediately call for help. Sometimes the cord isn't as visible, but what you're going to see is fetal distress. Call for help. And then with a sterile glove, what you would do is you would go inside the cervix and lift the head off the cord. If it's prolapsed, you can actually feel the cord. You can feel it pulsating or not. You would lift the head off the cord and wait for help. Sometimes you can reposition mom in a knee chest or Trendelenburg to relieve some of that pressure. Regardless, if that cord doesn't slip back, you're going to be preparing for delivery, which would probably be an emergency C-section. You don't have much time to educate and provide emotional support. You're just going to say that, the cord has slipped through, it's a medical emergency, and we're just going to get them back to the OR as soon as possible for a good outcome. Of course, whenever there is a medical emergency, the charge nurse would be called, who would arrange the OR to be open and also arrange the NICU to be there at delivery, and the physician would come in for the delivery. Here's a picture of a loop of umbilical cord that has prolapsed, and you can see there how the head is now compressing against the cord, causing lack of oxygen to the baby. So in a cord prolapse, you would call for help, organize for delivery, relieve pressure on the cord, and get that baby delivered. Sometimes, to give us a little bit more time, we want to stop contractions. And sometimes we use medication to stop contractions. And one of those medications would be terbutaline. Terbutaline we give sub-Q. We could give 0.25 milligrams sub-Q. It's a tocolytic agent, meaning it's going to stop the contractions. The thing is with terbutaline, it will increase the heart rate of mom, which would increase the heart rate of baby. So if mom has a heart rate of 120 or greater, you would not be able to use this tocolytic agent. It is important always to assess mom's heart rate and, of course, her lung function as well. Once we give this tocolytic, contractions pretty much will subside rather immediately. We usually give it sub-Q either in the right or left arm. Again, it is a medical emergency. The cord prolapses that I've been involved with, I've gone in with my sterile glove, taken the head off the cord. I pretty much hop on the bed. They wheel both the mom and the baby, of course, with me holding the head up. I'm in the bed. We get to the OR. I hop off the bed. I go underneath the drapes. I've still got my hand holding that head off the cord. And once the doctor opens her up and says, okay, I relieve my hand, and then they deliver the baby. Most often it's C-section. There are a few cases that you can get delivered vaginally. And that's only if the baby is right there. If you have any questions, just bring them up to me individually, or you're going to be talking about this and reading more about this when you do a sim, your next sim. Thank you.